Okay, so when I was preparing the slides yesterday, just the EEG came up to 30, 40 slides. So I thought I'll just stick with EEG and we'll talk about MRI next time because otherwise it'll be too rushed. So you might have seen different EEG machines that we use in our NICUs and PICUs. On the left side, these are the older versions of the CFM and AEG machines, and these are the more recent ones. At Imperial, we use one of these, the latest ones. This is like a bipolar CFM monitor. For the PREVENT study, that's the study we are doing in India. We are using a combined EEG CFM machine, something which looks like this one here. Although not on that stand, we're using a laptop for that. So, but these are the different EEG and AEG machines. So what I thought is that I will cover, so much of the things I'm going to talk about will involve the infrastructure of the PREVENT study, which is a large study on babies with neonatal encephalopathy in India. So when I say large, the largest study in the UK and overseas was around 200 babies with encephalopathy done over 5 years. Now this involves around 2,000 babies with encephalopathy and 60,000 mothers. So it's a massive study. But I can show some of the infrastructure we're using to record EEG in that study. Now, there are three key things I want to talk about. One is the indication for doing EEG. Why bother doing an EEG or AEG in a baby with encephalopathy? Two is about the electrode placement. And the last thing is about interpretation. Often in most talks, you would just hear about, on your bedside, you just hear about how to interpret the CFM or AEG, which is actually the last part. Unless you get the first two right, the interpretation becomes often meaningless. I just show you this cake, which was baked by my 10-year-old nephew a few weeks back. So he kept on baking it till it had this nice brownie color. So it went on for about 1 hour or 2 hours of baking till it got crusted from outside and it was looking like a cake. But the moment you cut it, fluid was pouring out because he didn't get the ingredients right. So if you don't do those initial steps properly, you may have something which looks like cake, but it's just not eatable. It's something fluid inside, and that's often we get wrong. We don't worry about the minutiae of the electrode placements and getting artifact-free EEG, and then we think we can interpret that later on. But that is extremely difficult. So much of my talk is going to be about the practicalities of getting a good AEG and CFM monitoring in babies. Okay, so why bother doing an Amplitude Integrated EEG or CFM in a baby? I think there are three key indications. Just because you got a CFM monitor sitting in a corner, I don't think that should be an indication. Just because the technology is there, that should not be the reason why we use it. And often when you start using technology like that, you end up creating more harm than benefits. So the first indication, there are three indications I listed. One is for selecting babies who need treatment, which is cooling therapy that we use in the UK and other high-income countries. And the number two is about prognostication. What is the baby going to do later on once baby is recovered from encephalopathy? And the third one, and the most difficult one, is identifying and treating seizures. So these are the three key indications. I will briefly go through each one of these. So for selecting babies for cooling therapy, this is a criteria that was used in the TOBY trial. And now this has been used in the latest version of the BAPM guidelines for cooling as well. So essentially, you should have three criteria. One is the background about a historical evidence of perinatal asphyxia or an acute intrapartum insult, as evidenced by fetal acidosis. Number two, on clinical examination, baby should have features of moderate or severe encephalopathy. Now, that was well structured and defined in the NICHD cooling trial, but not so much in the TROPY trial. And in the TROPY trial, there was a third criteria, which was mandatory. That is, we should have an abnormal amplitude integrated EEG. So when I say abnormal, it could be either seizures with a normal background, or it could be voltage abnormality. The interpretation of EEG was simplified in the TOBY trial, mainly to look at the voltage abnormalities. And we'll come back to that in a minute. But that was a mandatory criteria. The AEG had to be abnormal for a baby to be cooled. Now, the second and bit confusing part of the guideline is, if you don't have an EEG, which is extremely unlikely in a neonatal unit in the UK, most babies will get put on an AEG soon after admission. Then you are allowed to cool the baby still. That's what the guidelines say. And that's where the confusion happens. So people often misinterpret that you don't need an EEG abnormality to cool the baby. That's not the case. This is only when you have an EEG. When you don't have an AEG available and baby is still clinically, baby is moderately or severely encephalopathic, you can still cool the baby. Now, what do? You have an AEG, but that is normal. Yeah. And then do you still cool that baby? Well, at least that is what it's happening in the UK and at Imperial quite often. People have misinterpreted these guidelines and kind of started thinking you don't need to have an abnormal AEG to do cooling therapy. When you do that, you are actually cooling babies with mild encephalopathy. And that is not an evidence-based practice. We don't have the safety and efficacy data to say cooling is beneficial for mild encephalopathy. But we are doing a trial called COMET trial, which stands for cooling in mild encephalopathy. So if you come across babies with encephalopathy, but the CFM AEG is normal, do recruit to this trial. So Imperial PI is Gaurav Tricha. So bleep him or contact him and see if the baby can be recruited into the trial. So that trial has got two arms. One, we are randomizing within 6 hours of birth into cooling or usual care. That's one arm of the study. And the second arm is babies who are already getting cooling therapy. We randomize them to rewarming at 48 hours versus 72 hours of rewarming. So that's the COMET trial. But that's sidetracking a bit. Now, if we are doing cooling therapy based on a neuro exam, it's essential that you do the neuro exam properly. So there is a systematic way of doing neuro exam. And there's a separate talk on that. Nicola would have pre-recorded talk, and then if needed, I can do this training on neuro exam again, which classifies babies into 6 different categories, and then 6 different abnormalities, and then classifies them into mild, moderate, or severe encephalopathy. So that's one use of CFM. Now, second indication is prognostication. But the issue with prognostication within 6 hours is if you do a good neuro exam, that is as good as having an amplitude integrated EEG. So the area under the curve for predicting adverse outcomes is similar within 6 hours of age for both amplitude integrated EEG and the neuro exam. But so this is a systematic review we did a few years back, looking at the prognostic accuracy of amplitude integrated EEG at various ages after birth. So this is the accuracy for predicting long-term adverse outcomes at 1 year or more. So if you're an abnormal CFM within 6 hours of birth, that has got a very high sensitivity, but a very poor specificity. So if you have a normal CFM at that stage, it's very unlikely that this baby is going to have major issues later on and probably don't need cooling therapy. Like I said, most of these babies will be mildly encephalopathic. But if you have an abnormal AEG, it doesn't mean that the baby will necessarily have an adverse outcome. So that is within 6 hours of age. And if you, as the age keeps on increasing, the sensitivity keeps on decreasing and specificity will keep on increasing. So if you have persistent EEG abnormality at 72 hours of age, that baby, that has got a very high specificity, and that baby is very likely to have adverse, long-term adverse outcomes, although sensitivity drops. So this is at times useful when we are considering withdrawal of life support. So if the EEG is persistently abnormal at 48 or 72 hours of age, that would be one of the things that we may use to decide about redirection of life support. Now, the third and the most difficult and most important one is identifying the seizures. And again, like I said, unless we get the ingredients of the cake right, it's nearly impossible to accurately diagnose seizures from EEG. Because technically, you can mimic any seizures by just tapping on the electrodes or by using some artifacts. So it's absolutely essential when you acquire the EEG, you have the lead placement correct and all the artifact issues sorted before you try and interpret that. Okay, so those are the three main indications of using Amplitude Integrated EEG. Okay, now, so this is the key thing. So why is electrode placement important? We, in an Amplitude Integrated EEG, we are using a very limited number of channels. Essentially, if it is two leads, you just use the C3 and C4. If it's bipolar, you use the parietal leads as well, as opposed to the full montage of the traditional 10-20 system of EEG. Now, but it's important to get the position of these electrodes right. In the PREVENT study, we are using a reduced number of electrodes, which are labeled here. So these are the ones in green and red are the electrodes, reduced number of electrodes using that we're using in the PREVENT study. Now, this slide was made by one of our neurophysiologists from Great Ormond Street, with whom we are collaborating on the PREVENT study. And they are suggesting this is a reduced montage of electrodes. But even with this reduced montage, you can see a baby's head will easily get filled in very quickly when you put 11 or 12 electrodes. So this is the internationally accepted system of labeling the electrodes. We label from, so F is frontals, C is central, T is temporal, P parietal, and O occipital. The Z ones are for the midline, and even numbers are for the right side, and odd numbers are for the left side. So this is a standard internationally accepted way of putting the electrodes. Now, the only issue is that these markings are not visible. So the babies are not with the markings, with these markings of C3, P4 on their head. So we need to make a judgment call. It's not a judgment call. Once you get used to it, you can put these electrodes pretty accurately. So some of them are straightforward. So the first one we do is this one called ground electrodes, which is on the Nassian. And then the second one we do is the CZ one, which is it's not an electrode, it's the a positioning that we use, which is just behind the anterior fontanelle. And then we need to put C3 and C4 for Amplitude Integrated EEG. And how we do that is by taking the midpoint between the C set and T3. So T3, the temporal one, is just 1 centimeters above your ears. So you take a midpoint from the vertex of your head to 1 centimeters above the ears, and the midpoint of that is C3. So that's not too bad. More difficult is finding the position of the P3, which is actually the midpoint of these two leads there. I'll describe this in a bit more detail in the next one. Midpoint of, so this is an imaginary line between P set and T5, and then a line between C3 and O1, and that's the midpoint is the P3. Now, like I said, the first one you do the Nessian, there you're done, and then the second one on the vertex, that's your C set, and C3 is halfway between C set and T3, and T3 is 1 centimeters above your ears. Then so that you have your C3 on either sides. Once you have that, you try and get the P3 and P4 by finding the O1 first, the occipital midline one, OZ1 first, which is just one finger breadth above the bony prominence on the back of your head, on the just above inion. 1 centimeter above that is your OZ. And then 1 centimeters on either side is your T3 and T4, and the midway between C set and O set is your P set. So I won't go into, I'll leave these slides here for you to kind of use it as a reference. It may look quite complicated now when I explain, but when you actually do it a few times, it just becomes automatic. It's just like the ingredients of the cake. Once you learn to bake the cake, get it right consistently, it just becomes habit, and it's easy to get the electrode position right. Now, once you put all the electrodes in, it should be symmetrical and equidistant apart. Now, for applying the electrodes, it's absolutely essential that we follow a standard system and prepare the head, prepare the scalp of the baby well. So for preparation, we use something called new prep, and then for attaching the electrodes, we use a conductive jelly. And then you just need some sticky plasters, your electrodes, and something called tubing grip to keep the electrodes in place. So these are the equipments that you need for placing the EEG leads. And for preparing the skin, you also need this kind of earbuds, and that's what we use. So you take out a little bit of new prep. This is kind of abrasive to prepare the skin. And once you prepare the skin, you put the conductive paste and then stick the electrodes on with the knee fix. And we use Surgifix to fix the electrodes after that. So this is how you attach the electrodes. So hair is not not a barrier in getting good quality EEG, provided you do the preparation properly. So you need to part the hair well. You can either do with your fingers or with the earbuds. Once you part the hair properly, you then apply the new prep and prepare the skin. You just need to rub for about 30 seconds, and that's all you need. And then once you're prepared, then you apply the electrode and put a sticky plaster on. It sounds so simple, but unless you do it in this way, in a systematic way, you'll not get good quality EEG, and you'll have a lot of artifacts. And once you have all the electrodes in place, you should have a very low impedance of less than 10 ohms ideally, and your electrodes position should turn green. Okay, now so that's the preparation bit. The last bit is not that difficult actually. It's just the interpretation bit is just is a piece of cake. But I'll take you through the key differences between an amplitude integrated EEG and the traditional full montage EEG. So on the top here, you're seeing the full montage EEG. So you got Your signals, positive signals, negative signals going up, down, like that. So there are 5 or 6 different steps in converting that EEG into an amplitude integrated EEG. In reality, amplitude integrated EEG lose a lot of data and signals, and is a kind of poor man's tool. And traditionally, most neurophysiologists don't like to use amplitude integrated EEG because you don't get as much as information as a full montage EEG. But the advantages is that you can do it for longer time, and you can make some decisions based on the EEG at bedside. Because if you are doing a full montage EEG just for 30 minutes or an hour, an EEG technician coming and doing an EEG in your NICU, it's not that useful because often you don't pick up any seizures during that time, and it's rarely used for any real-time clinical decision making. So we do need to have something at bedside, but the traditional EEG is too complex or too difficult for the clinical staff to both to apply and to interpret. And that's how amplitude integrated EEG has come into standard clinical practice in neonatal units in the UK and many other high-income countries. Okay, so the first one, EEG, you're seeing positive waves and downward waves. The first step in converting this into an amplitude integrated EEG is to filter out some of the noises that you don't want. Then you do something called a log transformation. It's a semi-log transformation. So by this, what I mean is that so here you see the scale, which is going from 0 to 50. Up to 10, there is no log transformation. And the transformation occurs only about 10 to 100, and that's on a log scale. So the scale is uniform. The distance between each of the units is uniform up to 10, and after between 10 and 100, it's not. It's log transformed. So that is the semi-log transformation. And then there's a step called rectification, where only negative signals are converted to positive. So in amplitude integrated EEG, we have only positive signals. All the negative ones are inverted up. Then it is converted, it's compressed in time to get the amplitude integrated EEG signal. So in the top one, the whole of the top trace is now compressed in time to get the last trace. And how this is done is that the computer takes on every 15 seconds, it calculates what's the highest amplitude and plot it there, and what is the lowest amplitude at that time. During that 15 seconds, you plot it there. So the highest and lowest, you keep on plotting every 15 seconds, and that gives you the compressed AEG display. Now, so this is the kind of compression going on. So from the raw EEG, so this is just one EEG taken at the square, within this red rectangle here, and the whole trace. The standard speed for AEG is 6 centimeters per hour, or 1 centimeter every 10 minutes, and we should not alter that speed. Now, when you look on the scales, like I said, between 0 and 10, and this is a standard scale. So the distance between 0 and 5 and 5 and 10 is fine, it's same. But between 10 and 100, it's a log scale. So that scale is not uniform. This is quite useful in babies because most of the babies have voltages in the lower area, below 10. Now, a normal EEG trace should have a lower, the voltage of the lower part should be more than 5, and the upper should be more than 10. And how you look at that is look at not just this spikes here, look at the dense portion, where the draw a line of the dense portion and see where the dense portion is. So the upper margin, so the lower margin should be more than 5, which is here, and the upper margin is somewhere here, The dense one, that's more than 10. So that's the normal voltage of an amplitude integrated EEG. The second thing you see here is a sleep wave cycling. So it's kind of narrowed some places and then brought at other places. And that's the normal thing that you should see in an AEG of a healthy baby. At times you see asymmetry in the voltage, and often this is not due to any pathology. It's not due to, if you have stroke, of course, you may have voltage differences on either side, but often this is due to either the lead placement or some swelling or some edema on that side, maybe lying on that side. Because remember, we're transmitting the EEG signals from the surface of the brain, from the cortical areas. And if you have swelling, scalp edema, the voltage in that area will reduce, and it may give an appearance like this. Now, there are 5 different patterns that we need to know of, and only 5 different patterns. And it's not that difficult to learn these patterns and interpret this correctly. The normal pattern, like I said, is a continuous normal voltage, where your voltage should be, the lower margin should be more than 5. So this is 5 here, should more than 5, and the upper should be more than 10. And it should have this nice snaky appearance of the sleep wave cycling. Now, when babies have mild encephalopathy, often the voltage remains normal, but they lose the sleep wave cycling. And that's a feature of we see very commonly in babies with mild encephalopathy. Now, in preterm babies, often we get discontinuous EEG, where you have spikes and then said a discontinuity, which is shown as a broadening of the trace on an amplitude integrated EEG. So your lower border is now less than 5, but the upper one remains more than 10. And that's a discontinuous EEG. This could be a normal thing in preterm babies, but possibly abnormal in term babies. It may be often it's seen in mild encephalopathy, but at times in babies with moderate encephalopathy. But if you have any abnormality beyond discontinuous, including discontinuous, that's an indication for cooling therapy. Now, there are 3 definite abnormal patterns. One is burst suppression, and the second one is low voltage, and the third one, and the most sinister one, is a flat or isoelectric pattern. So when we say burst suppression, sorry, let me show you some more trace of the normal voltage. So you can see here, that's the normal trace, low margin more than 5 here, upper margin more than 10, a nice snaky appearance of the sleep wave cycling. And so this is sleep wave cycling I mentioned. This is because you get often discontinuity during quiet sleep, and that's manifest as a broadening of the trace. Now, the discontinuous pattern, like I said, it could be normal in preterms, or it can occur in mild HI, or when you're giving some sedative drugs to the babies. Now, in burst suppression, there are 2 different types of burst suppression we see. One is a dense pattern, and the other is more sinister one is a sparse pattern. So what you're seeing in the burst suppression is that you're having a lot of burst with often high amplitude, often reaching up to 25 microvolts, but the lower margin is really down. So it's like it gives an appearance of a hair comb, and dense one is it's a very narrow comb, and the sparse one is, it's got a spread out comb appearance. And both these are abnormal patterns and often associated with adverse outcomes. So so this pattern will give you that kind of comby appearance. The lower margin has gone down, it's abnormal, less than 5 in both, but the upper margin, as you can see, has got a lot of the spikes. The spikes are much more frequent in the dense one, and much lesser in the sparse one. Now, the second abnormal pattern is low voltage. So here, your lower margin is quite low. It's almost just above 0 there, and upper margin is around 5 or just below 5. So that's low voltage. Again, that is abnormal if you see it at any age. Now, the most sinister one is a flat trace where your voltage is just at the bottom near zero, and of course there is no sleep wave cycling. This is again associated with very poor prognosis. So these are the 5 patterns you need to know of: your normal trace, and then the discontinuous one, which could be normal in preterms or maybe just mild end of brain injury, and the 3 clearly abnormal patterns: burst suppression, low voltage, and isoelectric patterns. Okay. Now, when seizures occur, to identify seizures in an AEG, you often see an elevation of the baseline. So here, it's an arch-like elevation. It's a sudden elevation, which is sustained for some time, and then it comes down. So the lower margin goes up, both upper and lower margin goes up. So the entire thing is elevated. And often, if it is persisted, it gives a sawtooth appearance of repetitive seizures or status. And this is the classical appearance of neonatal seizures or status on CFM. But it may not be always easy to identify though. So this one is easy. When there is a long and bilateral seizures, you can very easily see it on a CFM. Seizures are happening there. You've got the arch appearance, elevation on the baseline, narrowing, repetitive seizures. You can spot that quite well. So this one again, this is a baby in status. You can see the typical sawtooth pattern, arch elevation of the baseline. Again, seizures easy to identify on CFM. This one is more difficult when you have long amplitude seizures. Low amplitude seizures. It may be easily missed on the CFM. Now, let me show you this video, which there's a talk by Ronit Plesser.
My name is Ronit Plesser.
She did in
consultant in clinical neurophysiology and pediatric epilepsy at Great Ormond Street Hospital. And it's a really a great honor for me that I'm part of this team. So I'll be responsible for the EEG in the neonatal period and for neonatal seizures, plus EEG in the infant or in the young children at 1.5. And so what I want to do is initially talk a bit about neonatal seizures and how we diagnose them, and then later give you an overview on the use of aEEG. And Mariana and Jessica, who are clinical physiologists, EEG technicians at Great Ormond Street, have been very kindly have agreed to come and help us with learning how to set up the EEG, which really initially is the biggest hurdle, how to set up EEG at a high standard with a good quality EEG. So they are going to talk about later how to do the.
That's absolutely vital. Getting good quality EEG is absolutely vital. I won't go through the whole video because it's about 2.5 hours. Let me show you some part where they're showing the setup of the EEG.
P for parietal and O for occipital. And then the same for the left. FP2, F4, C4, P4, O2. So you have, this is the normal display for the 1020. But this head box is opposite. It's opposite, yeah. This is why it's important that you remember that even numbers, F2, F4, FP2, F4, C4, P4, O2, everything which is always right. But this is internationally. Yeah. Everywhere where you go, it's always the same. The colors may change, but the numbers, even and odd, is always the same. And you have F for frontal lobe, C for central area, T for temporal, P for parietal, and O for occipital. And then the same for the left. So here, the head box shows you that the left is on this side and the right on this side. And then you have to make sure that you have the right electrodes going to right and the left to left.
Yeah, so Marianne's taking extra care of just placing them. She's placing them and then plugging them in. So there's no uncertainty about what wire she's placed and where it's going.
Yeah, so absolutely. What you shouldn't do is place all the electrodes and then plug them in all together, because you mix them up. However careful you will be, you will mix them up. So you just prepare one, you stick it on, and then you stick it into you plug it in.
So I'll show you some. So this is how you're preparing. You're parting the skin and applying new prep now.
Make sure you part your hair. Part this side. Just make sure it's in line. So just use your hands basically. So you got this, and then just make sure it's in line. There we go. So which one should I go next?
So that's your C3 going there.
So we'll try to do the right side now. You might just need to move the baby's head. So I'm just going to move the...
And then once you got all the electrodes now, all the electrodes are fixed. Now you need to put the cap on, otherwise the electrodes will not stay in place properly.
help
and this is
to
how you do that.
Hold at the front,
you
or you can just
gauze.
try and put this straight down. So I'm going to get Jess to hold the front of the hat, and then I am going to slide it under, taking the wires with me, pulling it right out to the neck, and then I'll ask this lady to put the baby down. Thanks very much for your help. And then once the hat is on, we can just slide it under the baby's chin. There we go. And then again, do a visual check. You can lift the baby's head yourself now, and just make sure the hat is going right down to the neck. And this wire, as you can see, this wire is thanks. This wire is kind of hanging there, so you can find it and just pull it, and it'll make it easier. There's no loops. And then when you show your hat is okay,
these little things makes a big difference when you are connecting EEG for a long time.
And then you can grab all your electrodes on one side and put them all together.
Now I'll just show you the interpretation of the EEG in this case.
Here, then you can see that the EEG activity is fairly symmetrical on the right and the left, but the background activity is, you have bursts of high amplitude, spiky activity, abnormal activity, and periods of suppression. So this is what we call a burst suppression pattern. It's different to the burst suppression pattern in AEG. This is burst suppression pattern of EEG. And basically, this is a sign of Otohara syndrome. So even though we didn't capture seizures, a baby who has burst suppression pattern bilateral dose suppression pattern at that age is plus the history of tonic seizures from the neonatal period onwards is very likely to be a genetic form of Otto-Harmer syndrome.
So this was a very...
The other thing which is interesting is that, I mean, you can see all the spiky elements here, all the discharges. So there are multifocal discharges everywhere. And then that alternates with periods of suppression. So yeah, you have the suppression. And it's slightly different in sleep and wakefulness. So when we woke the baby up at the end, the burst suppression pattern disappeared for a bit.
Okay, I'll stop there. Now, before we finish off, I'm just going to hand this over to Salah, who is showing there's an EEG recording going on in one of our study sites in Calicut. And let's see if we can share that screen. Salah, can you share your screen of the EEG? Yeah, so this is a baby whom they're doing an AEG in Calicut, in Kerala.
Yeah. So thank you. So I'll just go through the software first. This is the neurospectrum software which we use in Calicut. Today we have a baby's follow-up EEG. This was a term baby born and had a third day, the baby had a clinical seizure, following which the baby was started on phenobarbital. Now this is the day 7 of the baby, and after stopping the phenobarbital for the past 3 days, we are doing a follow-up EEG. So you can see, as you can see here in the screen, can you see the screen? Can you see the screen?
Yes, Salah, go on.
So when you see the screen here in the top frame, there is the Amplitude Integrated EEG, which already has been discussed. So we are using mainly 4 leads. For the left side, we have C3P3, and for the right side, we have C4P4. So 2 channels, we have Amplitude Integrated EEG. And in this Amplitude Integrated EEG, we can see that the lower margin is above 5, and the upper margin is around 10, not really above 10. So, and it is symmetrical. So this is what we actually look for, and we also look for any abnormal rise of the AEG band, which may suggest for seizures. So that you can't see any such bands here. And on the lower frame, we can see the raw EEG. We have a reduced montage raw EEG. And this is showing fairly continuous activity, but the amplitude is on a lower side, and the frequency is also little on the low side. Now the baby, as you can see in the video, the baby is moving a bit, and that is causing some movement artifacts in the EEG. That is because of the movement of the electrodes. So I'll just show you the montage before I go to the baby. So this is as it was discussed in neonatal EEG. It's very important that we get the impedance right. The impedance should be as low as possible. So this is, as you can see, if it is green, it is less than 10. So we have all the electrodes in good range of impedance. And another important issue to make sure is that it is symmetrical on the both sides. So that will affect the interpretation if it is not symmetrical. Symmetrical equidistance between the leads should be there. So as the nomenclature has been discussed already, so the odd ones are for the left, even ones are for the right side. Central ones we label as Z. And there is, for the frontal we mark as F, for the temporal we mark as T, and for the parietal we mark as P, and for the occipital we mark as O. And we also have some electrodes to look at the ECG, as well as look at the EMG and respiratory band. We also have a respiratory band to look at the respiration of the thoracic effort of the baby. This is because we need to know, we need to look at any artifacts which to identify artifacts from ECG and all, these reports are needed, as well as to identify whether the baby is sleeping, whether there was any movement in the baby and all. We need EMG electrodes, and whether the respiration is regular, we need the thoracic effort. So now I'll just go to the baby now. Baby sleeping. So I'll just first increase the size of the. So now, as I'm showing, I'll just make a comment that we are going to handle the baby. I've just made a comment that there's a procedure, so we will be handling the baby, and I will show the video of the baby now, just to show you the electrodes. So first, so as you can see, this is our EEG setup, and this is our EEG machine. So we have already placed all the electrodes, and baby is sleeping right sleep. So these are the electrodes neatly tied up so that we don't have any artifacts. And this is the thoracic effort band, respiratory band. And so now I'll just take help of Dr. So this is nicely. So as discussed, just above the nasion, we keep the ground electrode that has been placed just above the nasion, 2 fingers above the nasion. After which we have to look at the midpoint between the nasion and the neon in the back, and just behind the anterior frontal end. And it is also it should be also crossed by between. So if you draw a line from both ears and the neon and the the nasion and the neon, there's a crisscross should happen, and that area is a CZ. This shows the CZ. That is the central area. The most central area CZ, and just above the ear we will have, from the left side it will be T3, and on the right side it will be T4. And as discussed, first we place the CZ, then we put the T3 and T4. In the middle of these two would be the for the right side it will be C4, and for the left side it will be T3. So we'll have a arch already formed. We have the ground here and CZ. After that, we actually go to the back and find the neon, and just above the neon there is the OZ, and as discussed, on the right and left we have O1 and O2. And after that we have to put the electrodes, which one of the electrode is on the right side we say P4, and on the left side P3. That was how we identify the electrodes is that between on the right side it will be T4 and O2. To go middle it will be T6, and middle of CZ and OZ is the place where we keep a reference electrode as a PZ. So if you draw a line like this, and a line crossing from O2, and on the right side it is P4, you will get the exact point where we have to keep the P4. So this is the right side we are saying. So one thing is, just by measuring we get, and then we have to make sure that it should be equidistant, and it should be in line with the O2 and the C4 above, and it should be equidistant. Same thing we do on the other side also. Now when we come to the front, we have an additional electrode which we have to keep, that is the F4. So again, also here also we need to know the adjacent electrodes to identify the position, exact position of this F4. And the main thing here also, it is important to have F4 and C4 should be having an equal distance from F4 C4 as well as C4 P4, and it should be in line. And this F4 should have on the symmetrical side, on the other side there will be F3 also. So main important things are to make it sure that it is symmetrical and just equidistant, and it is going in line. So for all the sagittal electrodes, we should make sure it is going in line with the ground, And for the parasagittal electrodes, we should make sure all F4, C4, and P4 and O2 are in a curvilinear line. And the transfers also we have to make sure T3, C4, Z, C4 and T4 are in a line and it is in equidistance. Basically, this is the most important one. We have to get the impedance right, and we need to make sure that electrodes are equidistant and symmetrical. That's from my side.
Thank you, Salah. That's wonderful. I mean, hats off to you, team. We've been trying to do this for many years in the UK and still not have managed. This is such a high quality EEG. This is with the notch filter off, isn't it?
I'm sorry?
The notch filter.
Yeah. This is with the notch filter off.
Absolutely. Yeah, it's a really high quality EEGs you're able to get. Okay, well done.
Thank you.
Okay. Fine. I think we should stop here. And I think it's mainly our team in the Zoom. Okay. Any questions? You can just unmute yourself and ask or put in the chat. So EEG people, Vaishnavi, Manu, how are you finding it? Nizam is not there, isn't it? Okay.
I'm Manu here.
Hi, Manu. Yeah.
Hello, sir. And EEGs looks fine, I think. Hello?
Yeah. It just getting that preparation is so vital, isn't it? Getting the impedance right. Yeah, if you get that right from the beginning, then you have good quality recording, and you can make accurate interpretation based on that.
Thank you. Okay. On the upcoming days, I will try to improve my level best.
Thank you.
Thank you. Yes, sir.
Any questions?
Sorry, if this is EMG and ECG electrodes are in right.
Yeah, so we are collecting the.
Sometimes we didn't get the proper impedance on the EMG and ECG electrodes. I think in this EEG, the both electrode waves are correct in right form, right? Yes, sir.
Yeah, is it to do with the ECG leads? Because we are using the standard ECG leads for that, isn't it? Seller for the EMG.
Yes, we are using the standard, but sometimes due to hair and all, sometimes the impedance is not really good in those leads. We are working on it to improve that. But the other, only the extracranial leads, there's some problem with impedance.
This you're putting over deltoid.
Yeah, deltoid. Yeah, deltoid, and the tip of the shoulder for the ECG. Okay,
yeah, fine. Just ask Jess and Mariana if they're got any suggestions.
Sure.
Yeah. Good. Okay. I think if no further questions, let's just stop here. And thank you so much, all of you, for joining in. Nicola, do you want to announce the next speaker?
Thank you very much. Yes, just to confirm for everybody, next week we've got Nicola Bridges speaking to us on what to do about short stature. And obviously all of you are very welcome. We'll make sure that you have the link, and then you can join us for any of the sessions in the upcoming autumn term. So huge thanks for today's session, and enjoy the rest of your day.
Thank you so much. Bye-bye.
Thanks very much, Sudhin and Nicola. Appreciate that. And thanks for opening the batting so capably, Sudhin, with your team. And thanks to all who contributed.
Thank you, Andy. Bye-bye.
Bye-bye.